Well, for a long time now, one hospital in particular in Gauteng has been nicknamed Caesar's Palace, or at least that's what I've been told, pointing to the rumour that births are more often than not by C-section rather than natural. Whether this is the convenience of the consultant method of operating still exists or even ever existed is questioned today. And we look at different methods of birthing your baby with our three experts. Now, I have Dr. Nick Clark, who is a reproductive, I've got down medicine specialist. Is it medical specialist? Yes, medicine specialist. A gynecologist with MedFem Fertility Clinic. And then Mari Hattingh, who is also in studio, who is the Genesis Clinic manager and birth basic support specialist. And then on the line, I have Ruth Ehrhardt, who is a certified professional midwife and doula, and I don't know what that means. So welcome to all three of you.
Thanks.
Thank you.
Now, Ruth, are you there?
Yes, I'm here.
Oh, good. Excellent, excellent. Sorry. Now, I suppose the most natural birth of all is to have baby at home. And anyone who's been watching Call the Midwife on BBC Prime has been treated to how things used to be in the East End of London. Is there anyone here, out of all three of you, who would advocate that today? Are we sort of returning to that view of having a home birth? What about you, Nick?
Look, I think the absolute key to any form of delivery, whether it's in a hospital, whether it's at home, depends on being able to provide the service. Provided you can give the necessary service and backup,
yes,
then the place of birth can be anywhere. So I think that that's absolutely key. And I mean, that goes for in public hospitals, private hospitals. There are situations where it might be safer to deliver one way than another just because of the services that are available, or not.
Yeah. Mari, what do you think?
I think absolutely a woman that has to birth has to be in a very comfortable environment, and if that should be her home and she is in the criteria of being a low risk for this pregnancy and birth, then with excellent backup and the midwife knowing what she's doing, there's a place for it.
Yeah. Ruth on the line, you are a midwife and a doula. I don't know what a doula is. What's that?
A doula is somebody who provides emotional, psychological and physical support for labour but doesn't provide medical support. So she's purely there to provide everything but the medical support for the mother and the father in labour.
Okay, and so are the majority of your deliveries at home or in a hospital?
At home.
Yeah. And how does that work? Do you advocate it?
Well, I would say that I provide information. That's why my colleague Lana Peterson and I started Home Birth South Africa. We started it in 2010, and at the time we were frustrated that there was no information in South Africa that women could find that was relevant to South Africa or in the context of South Africa around home birth. If you went online, it was all about American home births or UK home births or Australian home births. It felt like this very otherworldly, first world elite choice.
Which is sort of bizarre, isn't it, given the fact that it was thought to be very first world to have your baby in hospital.
Yes, exactly. Whereas, there has been a sort of a swing in the other direction because women wanted some autonomy in their birth choices. And, basically stepping into a hospital environment often meant that they were giving their rights away and had to conform to hospital guidelines and protocols and wanted a bit more choice in the matter. So
you've got to be a very, very strong person to start issuing orders when you're sort of in the middle of giving birth as to what you do and don't want.
Well, I think you're very vulnerable when you're giving birth. So you want to know, some women want to know that the people that are present and the environment that they're in allows them to be vulnerable and that they can trust and let go completely, which is essential for giving birth. You need to be able to just let go of having to think and give orders and make decisions. You want to know that the people that are around you, you can trust completely. So I think that's part of the reason women choose home birth.
Ruth, are there any figures as to, or studies as to how people relate to baby or how they feel about the birth, the baby, the process in terms of hospital versus home?
not so much in South Africa, unfortunately. Here we don't seem to have much around that, but we do have a lot of information around how women bond with their babies in terms of their birthing experience. So if a woman feels empowered, she feels supported, then definitely the caesarian rate comes down, intervention rates come down, and as a result, her bonding with her baby definitely goes up. So whether it's in a hospital or home environment, I mean, you asked earlier whether I advocate home birth. I advocate that women give birth where they feel most comfortable and where they feel that they can actually just, well, comfortable not in the sense of physical comfort, but emotional comfort.
Yeah, okay. Mari, would you say that there are processes that are activated when one gives birth naturally as opposed to having a Caesar? And I freely, one can see that you wouldn't choose to have a Caesar unless you absolutely had to have one. But are there things that are activated through that natural childbirth process?
Oh yes, absolutely. There's what we call a birth cocktail, and that is all those hormones that kicks in when you're in labor. So for the birth to work nicely, your mother needs to be calm and relaxed. You have to have the perfect environment for her to do a normal, natural birth. And also the benefits for the baby, not only for the mom, but also for the baby. Being in a perfect environment and being supported with the right people and knowledge that people know when to identify risks and stuff. It's essential because the birthing process is beneficial to the baby itself, going through the birth canal, being just the getting in contact with the normal, natural nature of the moms and the birthing experience and the skin to skin afterwards. It is absolutely very, very important for that baby so that we can create this first immunization, which is actually happening during birth. And there's a lot of studies that's coming up now that is that what they call is that we need to get all of these microorganisms back into the baby when the baby was not born with a natural birth, that we have to do some.
Does that not happen with breastfeeding?
It not everything. There's some microbials that needs to be introduced to the baby that is essential for the baby's immunity. And it doesn't happen with the caesarean section because the baby's not going through the same pathway. Yeah. So the vaginal bacteria is actually playing a very huge role in this baby's new immunity. But it doesn't always have. The breastfeeding just supports that process as well.
Okay. Nick, we're going to be going into traffic, but I want to sort of come back to you about what you particularly advocate. Well, welcome back. If you've just tuned in, we're chatting about birthing options with Dr. Nicholas Clark, who's a reproductive medicine specialist and a gynecologist with MedFem Fertility Clinic. Mari Hattingh, who's Genesis Clinic Manager and Birth Basic Support Specialist, and then Ruth Ehrhardt, who's on the line. She's a certified professional midwife and doula. Nick, what do you advocate? I mean, obviously you're not going to tell people to have a caesarean unless they need it, but how do you deal with somebody who's determined to have a home birth or determined not to go to hospital?
I think I would like to return to something that Ruth said earlier, and that is that the key to all of this is information. And there was a very interesting study several years ago, I think from Monash University in Australia, looking at the perceptions and and what people are prepared to go through from a midwife point of view, from a patient point of view, and from a clinician point of view. And it was shown that there's quite a mismatch in terms of people's the sort of risks that they're prepared to take and the things that they would like to go through. And I think that's where a lot of work has been done and should continue to be done. I think the key is communication. It's not for us medically to tell people what they should do or what they shouldn't do. We offer advice, and we can offer advice based on clear data. I mean, there's a 270-odd page document that was published by the National Institute of Clinical Excellence in the UK and the Royal College about caesarean section, and that data is evidence-based, and there is room for everybody to do whatever they want to do, provided they are properly informed. and that the people who are looking after them are happy to look after them in the way they want to be looked after. One should never be shy to make sure that you work with people who offer the service that you want, and if they don't, then you move to somebody else.
Nick, do we have figures on, how many caesareans, say, are carried out in the UK versus here, and what the results are possibly in delaying that process if the baby or the mother is taking too long, for instance, to
I think we need to make
that baby?
We need to be very careful in how we look at what's happening here and what we're discussing. We're probably discussing primarily the private sector, which represents a very small percentage of the South African population. So if you look in the South African Medical Journal, I think it was in March of this year, there was the triennial report on maternal mortality was published, showing that for the average South African, caesarean section is associated with a higher complication rate than normal delivery. Now, clearly, there are different types of caesarean section. A caesarean section that's an emergency is a consequence of a trial of vaginal delivery, whereas an elective primary caesarean section where somebody is choosing or doing it for a particular reason is a very different scenario. So I think we must be careful who we're talking about, and whether we're representing the whole population here or whether we're representing a small percentage of the population.
Well, one certainly is aware that dependent on whether you're in a private facility or in a government hospital, the experience is completely and utterly different.
Absolutely. I mean, worldwide, the safest way to deliver, without question, is vaginal delivery. And, I think that people just need to be aware that there are so many different subgroups that, in a sense, the debate about what an individual chooses is very much dependent on what their personal circumstances are. So I think one can never advocate a form of delivery. It depends what you want to achieve. The primary benefit of undergoing a caesarean section where there are absolutely no medical indications probably are maternal. Primarily, a lot of the work has been published on protection of the pelvic floor. I think it's very important, from the baby's point of view, to look at that side. So I think we must be very cautious that we don't discuss this as without understanding that there are many, many subgroups, and the information is key. So counselling people correctly and allowing people choice based on quality information is absolutely key. And often they don't have that information, or they're not given that information in an objective way. We're human beings, egos are involved and all sorts of things, and I think this is can be a problem sometimes.
Would you advocate a caesarean section, for instance, if the baby was breached? Or, you, Nick, would you
I think that the move has been towards caesarean section for breach because of work that was published many years ago now. That work's come under question, and there are now new publications looking at whether it is sensible to have a caesarean section for all when it comes to breach. The problem there is litigation. Litigation has gone out of control, and in many countries, litigation has a major influence over how people practice. And I think we mustn't forget that litigation is very much obstetrically, it is the highest risk specialty in medicine, and the insurance fees are so high now that you have got to, for the clinician side, and I think that without question that will influence what doctors are prepared to take in terms of risk versus what other people might be prepared to take as risk. And like I said earlier, people must be comfortable with what they do. If they're not comfortable, then they must, offer, like anybody, to refer on to somebody who might be more comfortable. And if you read the NICE guidelines, it will say, if you're not comfortable to perform an elective primary caesarean section for no medical indication, then refer to a colleague and somebody who is prepared to, and these sorts of things. So I think, bottom line is we should not be shy to keep the conversation going. Yeah.
Is there Mari, from your point of view, is there a sort of shopping list that people come in with to say, into, say, Genesis and say, well, this is how I want it to proceed, or do they take advice?
I think they do take advice. They've got an idea, and obviously the people coming to Genesis is those who's already had some sort of education. They've been looking around and know that there's options, and they come to Genesis to see what the options are. What is the midwife's delivering for them, would it be the best way to go? Are they actually fitting in a low-risk criteria? Because that is what midwives do. We are only looking at low-risk patients to deliver. Therefore, we do need the gynecologists, the obstetricians to support us.
Of course.
Yeah,
that makes sense. We're going to go to a piece of music now and then into our news headlines. And this is Classic Lifestyle with me, Tamara LePine-Wiliams, and we are chatting about birthing options. And we now have Ruth on the line. Ruth, in terms of what you see as sort of caesarean versus, how often do you find that when you're visiting somebody and helping them give birth at home, that you have to call an ambulance or get them to a hospital in a hurry?
Well, in a hurry is, I think that's the myth we sort of need to dispel, is that a lot of the work is done in the pregnancy. We've been speaking about high risk and low risk. So the women that end up having a home birth have had a lot of work done in the pregnancy to eliminate a lot of those problems that would warrant a transfer.
Yes.
In the rare case that one does have to transfer, I think it would depend on the home birth midwife, but I think it's below 20%. And a transfer doesn't mean an emergency. It can be anything from, a first-time mother who's just not actually coping with the realities of labor and needs some kind of a pain relief support. So something like an epidural, which you can't have at home, would then have to happen in a hospital. Sometimes the baby's just not going to come out that way, so you make a slow move to hospital, and the mother might need an instrumental delivery, or
and that can't happen at home.
No, of course not. No. That all needs to be. That's when you need to hand over care to a specialist.
Yes.
So, in my experience, transfers from home are not your sort of sirens and breakneck speed, having to rush to hospital. It's this is not really going to happen here. Let's make a move to hospital. Midwife carries all the equipment that you would have in a labor ward in a hospital. So she's able to monitor the baby's heart rate, for example, during the labor. So if that isn't sounding good, then you would move through to hospital.
I can think of a few reasons why. I'm way past having children now, but were I to be faced with it today, I think being at home where you don't have sort of superbugs that are sort of currently lurking in various hospitals, where you would be the person who was looking after your baby, that it wouldn't be sort of kept in another room at night, and all this sort of thing. I'd feel I would sort of opt for that personally, but it is such a if one were able. Does that make sense? Does that sound?
Well, I think that is definitely a reason that women choose to birth at home. They want to know that they're going to be giving birth in their own home, getting into their own bed afterwards, that their partner can be with them, and that they won't be separated from their baby. But having said that, a lot of hospitals now do advocate rooming in and skin to skin and all of that. And the evidence shows that is the best thing for mother and baby.
And surely you can request it.
Oh, absolutely. But again, that's where you need to do your homework, because some hospitals are totally pro that, and there are some wonderful hospital births that I've attended which support all of that. And then there are hospitals who, it really just does feel like you're walking into the 1950s, and they don't even understand why somebody wants to breastfeed. So it's just important to know where you're giving birth and that they support your options. And I think that's what we keep saying.
Yes, it is. Okay, well, we're going to go now to a piece of music. It's by Handel, and it's the Water Music Suite number 3 in G major. That's the 6th movement, Gigue, and Orpheus Chamber Orchestra are performing it. We're listening there to Handel's Water Music Suite number 3 in G major. That was the 3rd movement. Mari, can we just ask you, have you got figures as to sort of caesareans versus natural childbirth, or in this country particularly?
Tomorrow I've just completed the latest CDC study that came out for South African caesarean section rate, and it's a difference between what is happening in public sector and in private sector. So in private sector we are looking at a very high caesarean section rate of 74% of C-sections. And in
74% C-sections in the private sector.
Yes.
Giving birth. 75% in the private sector are C-sections.
That's correct. Yes.
Wow. And obviously different in the So on what basis are they given 74% of them given C-sections?
I think again it comes back to the care provider and the patient, the client, and the agreement that they agree upon which they want the way to deliver the baby. And I think,
but is it medically based?
It's not all medically based. It might also just be a comfort.
Too posh to push.
Maybe, exactly. Or well, whatever the case might be, there might also be a lack of huge education that the patient just believes this is the way to go. Or there's a lot of instances where ladies get told, you need to go for an induction, which if you're a midwife and you start with your induction, you find, but this lady is not ready to have a normal birth. So it's not being handled correctly. And you can almost from the beginning say, we are going to do a C-section in the afternoon.
But if it's not being handled correctly in the private sector, what hope does one have in the government sector?
In the government sector, they are pushing for normal birth much more. I think.
So, do we have the percentage of that?
That obviously will be the 25 or 26% of the rest of the outcomes. And I think due to the lack of resources, the gynaes or the obstetricians in the public sector is basically one or two in the unit. And then the midwives are leading the public sector. They are doing the natural birth, and they would only call the obstetrician when there's a complication. Where it's the other way around in private. People go and see the obstetricians for birth. But we are trying to get midwives in South Africa to take back their role and to deliver these low-risk pregnancies and births.
And is that not happening?
It is starting to happen now. We can see a shift in it very slowly, but I think if we look into the next couple of years, a lot of private groups are going to start making that shift.
Okay. And Nick, I mean, are you sort of aware of that figure?
Yes, I'm very aware. But as I said before, I think one needs to be very cautious about interpreting these sorts of figures because they represent a wide range of different groups.
Yeah.
And as Ruth said earlier, there are high risk and there are low risk. A low risk person in pregnancy, the chances of a major problem is very small, and their chance of a normal delivery is very high. I think the point also that was made about preparation is absolutely key. If you prepare people well, and you ease them into the process in a relatively stress-free way, then they are more likely to achieve what they want to achieve. I think more and more nowadays in every aspect, even in the area that I work in with reproductive medicine, we know that balance in all aspects of life is really important. A holistic approach is the only way to go. You asked about doulas earlier on. Human beings are one of the animals that needs assistance when it comes to birth. And, one of the most important things in labour and probably at a caesarean section is support, a non-medical support. It's been shown that you decrease the risks if you've got somebody there who is a companion, who is
talking you through it.
Yes. And that doesn't have to be somebody that you necessarily, doesn't have to be a loved one. It can be somebody who does that for that's their task. It can be anybody. But the bottom line is it's absolutely key. So I think we should be very careful when we look at these figures, and they're not as shocking as they might seem. Also in the private sector in South Africa, there are groups, and there's a clinic in this town which has got neonatal outcomes that are way above many of the outcomes internationally when it comes to certain medical things. Again, there are problems with that because, what do we mean by outcomes? Are we talking about major outcomes, life and death, or are we talking about subtle outcomes which are more difficult to measure and maybe the studies are not quite as forthcoming? But I think we should be very careful. People generally, their motives are good. They are trying to do the best for their clients, and I think we should remember that and be careful that we don't turn it into a discussion about people's whether they know what they're doing or they don't, basically.
Yes, yeah. I suppose really, yeah. Absolutely. I suppose from a point of view of government hospitals, the whole thing is very, very different. And, having spoken to various people who have given birth in government hospitals, their experience has been vastly, vastly different. And when we're talking about a doula sitting next to you, I do know of somebody, personally who was left completely by herself the entire time. I think the so-called doula sort of came in and ate her lunch. Well, she was there, and 18 hours later she eventually gives birth, but without any help from anybody. And I think that sort of thing is sort of disgraceful, actually, first-time birth, and that does seem to be not unusual.
I think also another point to remember is that in the educated world, the more educated and the richer people are, the later they're having babies. Therefore, they represent a whole different risk category.
Yes.
So I think we must be very careful. Again, looking at groups in detail and knowing a lot more about them before. I mean, any private setup anywhere in the world has caesarean section rates that are very similar to South Africa. And obviously we cannot possibly compare the National Health Service in the UK or the National Health Service in Australia with the private sector in South Africa. They have nothing. There's no nothing to compare. So, again, we must be very careful how we... data is data. It needs a lot of information before you can analyse it properly.
I mean, I do know they are less likely to give you a caesarean on demand in the UK, and they're less likely to give you antibiotics. They'd rather you went through the whatever infection you had.
Look, there are very clear guidelines on recommendations, looking at things like clotting, because that's an issue. Delivery, looking at, for example, acid content in the stomach, looking at the antibiotic prophylaxis, which is routine, looking at the timing of birth. Timing of birth is really important, and I think that there's very clear data that the longer a baby is left to develop in the uterus, the better, without question. And I think that one can possibly be critical of timing of birth in some situations. I think that in my opinion, that's a major issue, that babies should be left in for as long as possible.
Yeah.
But again, there is the balance of the person who's making a clinical decision at the time, and they're assessing risk. And we've got to be careful that we know in any given situation what was actually going on.
But I think what you were saying earlier about litigation and insurance companies, I think that is just such a huge factor in the private sector, unfortunately, in South Africa.
Yeah.
And what you were talking about now about leaving babies to incubate in the womb for as long as possible, that definitely the high induction rate seems to lead to the high caesarean rate in the South African private sector.
Well, I think
definitely
yes.
an issue.
Yes.
Is there a high induction rate, and why is that?
Well, I mean, it seems to be varied, and I think it depends on each personal private practitioner's policy. But I tend to meet a lot of women post having been through a failed induction in the private sector who often feel that they were coerced or bullied or convinced at a time when they were very vulnerable, about 38 weeks. And convinced that was a good time to have that induction, and then that induction would fail, and they would end up with a caesarean section. So, it often depends what the reason that is given. It can be anything from your baby is too big to your amniotic fluid is too low. These are all sometimes can be valid reasons, and sometimes it can just be something that's sort of thrown about. But I think that the issue in all these cases is that these women often feel that they weren't part of the decision-making process, that they weren't actually provided with proper information around making that decision, and whether the reasons were valid or not. I think what we need to go back to is, are women actually part of the decision-making process? Are they understanding why these processes are happening, or these interventions are happening? And that's often the issue, that they feel violated.
Ruth, are there courses that pregnant parents can go to discuss all the options? Are they readily available?
Well, I mean, the reason we started Homebirth South Africa, that we do a quarterly gathering in Cape Town that people can come to that are curious, that want information, that want questions answered around home birth. So it's not about making people have a home birth, but it's so they can get that information. I think people can get a lot of stories and information from friends, especially if they are more likely to be on medical aid and be going the private sector route. So they have a lot of stories around inductions and hospital births and all of that. But there was very little information around home birth in South Africa. So that is something that we provide. Then there's something called the Positive Birth Movement as well. I don't know if it's completely national, but it's an international movement. And I know that there are 2 places in Cape Town that provide monthly meetings, and that is just about providing positive information around home birth and being not home birth, sorry, just normal birth, and being able to provide information and support parents who want to go that route.
Okay, Ruth, you've got a website which is, I'm going to give everybody, www.truemidwifery.
TrueMidwifery.com is my own personal website and blog, but Homebirth South Africa's website is homebirth.org.za.
Lovely. Okay, thank you for that. Mari, we're just looking at all the different ways of giving birth. The one in a bath, in water. Why is that so desirable?
The water birth. I love that topic. I think water birth, it's not for everyone. Obviously, not everyone is suitable for a water birth, but it works with some ladies. Some people just relaxes better into the water. The baby is being born from a water environment, amniotic fluid into a water environment. Obviously, there's some criteria. Your water temperature is essential. The type of the water, clarity, the cleaning, the salt that we put into the water to make it as compatible as possible to the natural environment of the baby. And research has been done on water births to say that no, your baby is not going to drown in the water because it's not being stimulated to breathe in the water, underneath the water. There's some chemoreceptors in the throat of the baby that actually needs to be in contact with air before the baby can be born, can breathe. So according to research, you can actually keep the baby after the birth for 7 minutes underneath the water, but we never do. We take them out immediately. But you'd often see your water babies being much more relaxed, much more calm. They don't always cry, and crying is not necessarily the best thing. People still think that, my baby needs to cry, the baby needs to cry. And it's not necessarily. It's all about the stresses.
Indication of life, I guess.
It's an indication of life, but the baby can be calm and come out and with the eyes wide open and alert and looking to his mom and not having any sedatives or anything in his body. And it's a nice, gentle birth for the baby.
Mari, so we'll give your website is www.lifehealthcare.
That's correct.
.co.za. So that's Genesis.
Genesis also got a separate one. We recently just purchased Genesis under Life Healthcare. So if they go on to Genesis Clinic, it will be www.genesisclinic.co.za.
And Nick, I mean, I don't know, you do a wonderful job because, I mean, people come to you presumably because they are struggling to fall pregnant. Is that right?
Yes, so that's my focus now. I would like to make a comment just from the things I've been listening to about pressure, really. I think a lot of women feel that there's a sort of a hierarchy of success, and if they don't achieve this, then in some way they've failed. They're very vulnerable. I think friends, family, we as doctors, midwives, everybody who comes into contact with pregnant women potentially can cause, emotional sort of fluctuations. And I think we need to, anybody who delivers a baby, in whatever way they deliver a baby, deserves the same credit. And I think we've got to be very careful about promoting and selling something, whether we are, from the medical point of view, and pregnant couples are inundated with sales pitches from many angles. And again, I'll go back to what I said earlier. I think information is key. People have got to do what's right for them, and they must not try to have a birth that is representative of somebody else's, their friends or family or any of these things. They must never feel pressured that, if they've not done something in some way, they haven't achieved the best for either them or their baby. And I think, we need to me, I feel strongly that people must do what they feel right. And going back to the idea of choice, if you're not comfortable with somebody, I think in this day and age, we should seek advice from people who resonate with us, and I think generally we do, and medically it should be no different. Okay, we seek out people that resonate. And
I hear you, and I don't know. There's something about what happens when people spy a pregnant woman is that every horror story known to man comes out of everybody's mouth. As soon as they see you, that number one, they all feel that they can touch you for some reason, and the other thing is that they tell you the most ghastly stories. And so you're right, you are vulnerable, and you have this wonderful idea of doing the whole thing without painkillers, and this is the sort of the best thing to do. But the bottom line is it's jolly painful, and if you want painkillers, have painkillers. Get through it.
In my experience, the story unfolds, and actually you don't need to do anything more than to just follow the path, and it becomes fairly clear how things are going to be. I think the idea of planning a birth, the minute you have a positive pregnancy test, is clearly absurd, and basically, the story unfolds, and that's it. You don't need to do anything.
As long as you've got that baby at the end of it.
That's it.
Really. Well, I do thank you all. We've run completely out of time. Dr. Nicholas Clark, you've got a website at MedFem, haven't you? So that's www.medfem.co.za. Mary Hattingh from Genesis Clinic, and Ruth Ehrhardt. Thank you all so much for joining us today.
Thank you.
Tamara.